once again, I'll tell you how we are going to study. The first thing is that we will start with the pathology, whatever pathology it is. For example, diabetes mellitus. So first we will talk about pathophysiology, about the disease. Then we will be talking about the clinical symptoms, then clinical diagnostics. For endocrine, mostly it will be how we are going to check the enzymes and stuff. Or maybe sometimes you might need iodine reuptake tests and all. So we will be talking about those. And then pharmacology. And in pharmacology, we are going to talk about the names of the drugs and how they work. So this will be our pattern. Okay. So so let's just start with diabetes mellitus first, because it's very important and it's very high yield also. Okay, so what's happening in diabetes mellitus? Anyone? What is diabetes mellitus?
In diabetes mellitus, you have insulin resistance that comes along. So, although the insulin that is produced is, a good amount of insulin is produced, the receptors are desensitized to the levels that are produced. And at one point, the insulin that is produced is not like it doesn't bind to the SGLT receptors, and there's no uptake of glucose that happens in the tissues in the bloodstream, and hence why the symptoms really arise, and that's why you have glucosuria and diabetic nephropathy and neuropathy and all the manifestations that arise. So it's not an impairing of production, but rather inability for the effect to happen.
Exactly. So when we talk about diabetes mellitus, first we talk about the type 1 and type 2, right? So it's very important to discuss that thing because it matters with the age thing. So we have to discuss those points also. So let's just start with this thing only. We will first distinguish between type 1 and type 2. Okay. Um, in type 1, what is the age factor? Like if the patient is coming with for example, there is glucose intolerance in the patient and the patient feels like he has to take sugar many times, and that person is also going for urination for many times, and the age of the person is 20. So what do you think, is it diabetes type 1 or diabetes type 2?
It would be type 1 because usually presents in a younger patient, and it's more of a it doesn't occur due to lifestyle issues, but rather is a genetic like it's usually due to various different genetic factors. So if a patient comes like that, I would check, like I feel diabetes mellitus 1 is more probable.
Yes, autoimmune disorder it is. So type 1 is autoimmune
Yeah.
disorder. So yes, for the pathophysiology of type 1, it is autoimmune type of destruction of the beta cells. Okay, so now we know that it is autoimmune. Okay, and the early onset. So age will be less than 30 years. Okay, what about DM2? For example, I'm telling that there comes a 42 years old obese patient, and he tells that he has problem with urination, and he is not able to sleep properly because he has to wake up many times for the urination. So and then you will test and you see that the blood sugars are very high. So what do you think? It's type 1 or type 2? Am I audible?
Yes, it was we mostly type 2 only because the age is more than 30 years old and the blood sugar is elevated also. And he's obese. It's mostly common in obese people, type 2.
Yes, in obese people also, okay. And it is also a type of metabolic disorder. And the point
Hmm.
here is that there is increased insulin resistivity. So insulin resistance is there. And this is the pathophysiology for type 2. And as the person grows or ages, there is progressive failure of the beta cells. So that is another reason for the diabetes to happen in older. And then you will see the age of the patient is over 40 years. So this is the first thing to distinguish. Whenever the case will come, you have to first figure out that this can be type 1 or type 2. Then we will think about what further we have to consider. You will see metabolic disorders. There are chances that in type 2 patients, you will see not only the diabetes, but also maybe hypertension and hyperlipidemia. So there are things that you should keep in stuff. Now, they might ask the question that which type of HLA system is associated with type 1. For USMLE, they will make your questions more tough. They know that everyone knows about diabetes mellitus, but how you can associate it more. So if we are talking about autoimmune disorder, it is associated with HLA DR3 and HLA DR4. So they might ask you a question like this. So you should know that, okay, if it is type 1, that can happen. Okay. So next question they will ask you about ketoacidosis, because in both of the cases, ketoacidosis is possible. And what is ketoacidosis? Okay. So let me give you a case where a patient comes in the emergency department, and that patient is 25 years old, and he has severe abdominal pain and vomiting. And when you come close to the patient to check further, you smell a fruity breath odor. And the person is, when you are asking question from that, the person is not in much sense, and he is having delirium. So what do you think?
That's definitely diabetic ketoacidosis, because you have fruity odor, abdominal pain, delirium, probably shows some hyperglycemic state, but something that's not being absorbed, the glucose, I mean. And yeah, like that's, and especially a young patient, and especially in diabetes mellitus, one diabetic ketoacidosis is more likely.
Yes, so diabetic ketoacidosis is more likely. And what is the reason for this? So the point is, they will give you, don't ask you that it is diabetic ketoacidosis or it is TPM type 1, because they know that
I'm very sorry to disturb you, but your audio is getting a little muffled in the middle of you speaking. Like it's not clear right now.
Okay, just a moment. I will check. So, yes, as you told about the diabetic ketoacidosis, so I was telling you that, okay, now you will be given a case that, yes, symptoms are there. They're not going to ask you about simple questions. They will make it more tough for you. So, diabetic ketoacidosis pathogenesis is important. So, first thing yet, okay, diabetic ketoacidosis is seen in DM type 1 and not in DM type 2. It could be, but mostly it's in type 1. And what happens here is that since maybe a person is not taking proper insulin injections, so what will happen if the person is not taking insulin properly, or if there is some stress, maybe stress means that body stress, maybe some infection happens or something like that. So what will happen? There will be lipolysis. So this lipolysis will lead to further oxidation of free fatty acids, and it will lead to ketone bodies. And these ketone bodies smell like, fruity breath. So this is the thing. So they might ask you that they will give you this case, and they will ask you what are the lab findings that will be increased. So what are the so first thing will be increase in the ketone bodies. What else will be increased? Now let me give you options. What about hydrogen ions? Then what about bicarbonates? And okay, urine ketones. If you have solved some USMLE questions, then you know that these type of questions are very common lab findings, and they will ask you that which one is increased, which one is decreased, like that. Then potassium. So what do you think? What will happen to hydrogen ions? Will it be increased or decreased?
It should be increased, I think, because it causes anion gap metabolic acidosis, right?
Yes, but it is increasing because of more anaerobic oxidation. So yes, K
Yeah,
plus,
that is.
sorry, H plus will be increased. What about bicarbonates?
I think it should be low
Why?
because you have more bicarbonate excretion. Actually, wait, on a second thought, I think bicarbonate would be high to buffer for the increased acidity in the body.
Oh, that is something different. That will happen. But since this is what you told before, you told that it is anion gap metabolic acidosis, right? And when there is
Yeah.
metabolic acidosis, bicarbonate will increase or decrease.
Bicarbonate should decrease.
Yes. So this will decrease because of anion gap, which is leading to metabolic acidosis. Okay. Okay. Now, what about urine ketones? Will it be increased or decreased?
Definitely increased, I think.
Yes. Okay. And what about potassium?
Hmm. I think intracellular potassium should be low, but serum is high. I could be wrong.
Okay. So when we are talking about the, okay, why?
Because see, okay, so I don't know how to describe it, but I know that like the body is in kind of like this hyper osmolar uh state. So the K plus kind of like shifts out of the cells. So it kind of depletes the potassium stores in the cells. And that's why the total potassium, like even though it may appear high, it's actually low because there's not enough for the cells to use.
Okay. So the
And because there's
when
not
the
enough
patient comes, yeah, when the patient comes in such situation, what we do, we check for two types of potassium. Okay, the one that is in the serum potassium, and one in like in the whole you know body, like total concentration. So the point is that it goes with insulin and K potassium. So we have to check this. When insulin is less, so you will see that in the serum potassium will be higher. Okay, so if it is low, this will be higher. So that's why in serum, you will see potassium is high. Okay. Now what happens is that since you know that there will be osmotic diuresis that you told. Why osmotic diuresis? Because to balance this metabolic acidosis, body will compensate. So when there is compensation thing happening, there will be reduction in the total body potassium. Why? Because there will be more K plus in urine. So this happens, but you should know that a very simple one, they are not going to ask you this much detail. They will give you this thing that, okay, what is about H plus? So it will be increased. Then they will ask you about the bicarbonates and it will be decreased. And then urine ketones will be high. And then they will give you K plus and it should be high. Okay, because they are asking you in the serum. So these reports they can give for this thing. Okay, now they might ask you one more question. For example, they are not giving you this lab activity. Then they might ask you, for example, complication. So what is the complication of diabetic ketoacidosis? Major complication. Okay, since you can see here that potassium is rising, right? So what it can lead to? It can lead to cardiac arrhythmias.
Oh yeah, arrhythmias, yeah, I was gonna say. And I feel brain cerebral edema as well could be happening.
Yeah, cerebral edema can happen, but the point is that once the patient is in initial state, we always go with the cardiac arrhythmia. We have to check all those things. This is the next level thing that cerebral edema can happen. Even if you will wait for a few more days, it can lead to mucormycosis infection also, because mucor infection is very common in diabetes mellitus. So all these complications are later onwards, but the first one that you have to consider because of the potassium, it is cardiac arrhythmia. Okay, so it's very important. And similarly, when you diabetic ketoacidosis, you will give fluids, insulin, and you have to continuously check potassium, because if potassium levels are not properly checked and maintained, it can lead to further complication of cardiac arrhythmias. Okay. Okay, so this was the first thing that they can ask you from a diabetes mellitus question. Okay, and mostly it's very rare they will ask a direct question, because it's very easy to answer those questions that, okay, this is DM type 1, this is DM type 2, but mostly they will ask you about the hyperglycemic emergencies. So now we know that, okay, this happened. There is one another case they can give you to distinguish. One is diabetic ketoacidosis and another one is hyperosmolar hyperglycemic state. So what is HHS? And how can you differentiate? Anyone? Okay. So HHS, what is happening here? That, for example, the patient has forgotten to take insulin injection. Okay. They have taken their food, and it is now, since there is no insulin, there will be hyperglycemia, right? So if there is hyperglycemia, the body will try to regulate that and it will do diuresis. So when diuresis happens, there will be obviously dehydration, and that will lead to hyperosmolar hyperglycemic state. Okay, it's very simple. The first thing, there will be high glucose. Okay, then if this glucose is high, there will be diuresis. When diuresis will happen, and if the patient is not taking proper water, then there will be dehydration. And when there will be dehydration, what will happen? There will be increase in osmolarity in the body. And when there is increase in the osmolarity, what it happens? What it leads to? It leads to HHS. So they might ask you this question, that maybe they have given you hyperglycemia, glycemic state, okay, and they will give you osmolarity also. Then you will see the pH, there is both in the pH. So first you can distinguish between both of them, like their pH was low or high in case of diabetic ketoacidosis.
In DK, pH should be low, right?
Yes. So their pH was low. Here there is no difference in the pH. pH is normal. There is no acidosis, and ketones won't be found. So now there is the point where you have to distinguish between these cases. There is DKA and HHS. They will give you this case. This is very high yield. That's why I started with this topic. So first, you will see increase in glucose in both of the cases. Now, the second thing is pH. So what's happening in this and in this? So pH here is reducing, but here it's normal. Then next thing, they can ask you about ketones, or they have given you this information. Here ketones are high, and here there is no ketones. So now you can distinguish that, okay, sorry. So now from here you can distinguish that if it is DK or HHS. Mostly HHS happens in EM type 2, but to confuse you, they can give you the case of a 25-year-old person. So it's not limited to just type 1 or type 2. So just to confuse you, they can give you this. Or even not this, they can give you that, okay, because you will see delirium in DK also. So what they will do, they will give some neurological deficits. So you can't distinguish with just with neurological deficits. So it's very important to read the lab findings. Now, from here you got that, okay, ketones are not there, and now they might ask treatment, or they might ask you the complication. So for the DK complication, I already told cardiac arrhythmia, and here it's coma or death. So it's more severe, and you have to do intensive fluids and insulin, and of course you have to check for potassium levels also. And here it was cardiac arrhythmia. So this way they will ask you the question, especially for diabetes mellitus. Okay, then let's talk about some more findings, because they will also give you some questions. For example, they might ask you about how things are happening when insulin is reduced. So there is one chart that you should understand, because sometimes they will give you the whole case and they will ask you about what is happening in case of lipolysis or proteolysis, gluconeogenesis, or osmotic diuresis, or maybe ketogenesis. So these are some words they will give you, and they will ask you that how you will see the changes in case of diabetes mellitus. So let's see how that thing happens. Okay, or they might give you some problems related to neuropathy and stuff. So they can ask you the question that, okay, the patient is suffering from neuropathy in the legs, okay, and they can ask you what is the reason for it. So let's, when it comes to insulin, what are the functions of insulin? What is the major function of insulin? Anyone?
Glucose uptake would be the most prominent. It has multiple, but glucose transport to skeletal muscles would be important, and adipose tissue.
Yes. So now, in the case of if there is absence of insulin, okay, now insulin is not sufficient. So body will somehow manage to take the glucose, right? So what it does, it will increase lipolysis. What is lipolysis?
Breakdown of fatty acid. I
Yes.
forgot what exactly,
Yes.
but like produces ketone bodies and one more product. I don't remember right now.
Yes. So it will increase the fatty acids, and that fatty acids further breakdown will lead to ketones. So that's why we see if lipolysis starts happening, there will be increase in ketones, and that will lead to which type of anion gap? Metabolic acidosis, anion gap. Okay, this is the first thing that will happen. Then the second thing is not only lipolysis will happen, there will be protein loss, protein breakdown also. So there will be proteolysis. So they might give you the question that the person is diabetes type 2, and the person lost their weight like 10 kgs in 3 months. Now, when we say that the person has lost the weight, we always consider cancer. But they have already told you that there is type 2 diabetes mellitus, and it means that there is decrease in the insulin. So there is more proteolysis. And they will ask you that what is the reason for this? You will get confused with the cancers. So no, not only in case of cancer, but even if there is less insulin, there will be more proteolysis, and there will be reduction in the muscle mass and the weight. Okay, so if proteolysis is there, you will see weight loss. Okay, now why this weight loss is happening? It is happening because it will help in gluconeogenesis. So you will see gluconeogenesis. Then along with that, there will be some other functions that will happen. That is glycogenolysis. So more glycogen will be broken down. What will happen if more glycogen is broken down? If glycogen is broken down, it will go into the urine. So more glycosuria will happen. Okay. Now, if there is more glucose going out of the urine, what it leads to? Leads to osmotic diuresis. And then further, you again go back to HHS. So this happens there. So if it is increased, this can lead to further problems. So they don't ask you very complicated biochemistry, but they ask you very simple one. Okay, but you should know how things are happening. Okay, so now you know if there is decrease in the insulin, what will happen? Lipolysis, proteolysis, gluconeogenesis, and glycogenolysis will happen. So So these are the main questions that they can ask you from here. Now, they can also ask about chronic complications that happen here. For example, they will give you a case for 56-year-old man who comes with retinopathy and neuropathy. And they ask that what is the reason for this pathophysiology of this retinopathy and neuropathy. So, when we talk about the complications of diabetes mellitus, there are too many things that is going on when there is too much of glucose inside the body. So the first thing happens is non-enzymatic glycation. What happens here? That this can happen at many vessels, maybe small vessels, large vessels. So depending on which type of vessels it is affecting, the problems will be related to that. So if it is retinopathy, neuropathy, if USMLE neuropathy is one of their favorite questions. So they will ask you about non-enzymatic glycation, and this word will be there, the option, and nephropathy. So these three things happen because of small vessel glycation that happens, and this will lead to what? This will lead to hyaline arteriosclerosis. So they might give you these terms, and they will ask you that what is happening there. So you should know the pathophysiology. Now, what there is problem with cerebrovascular diseases, or maybe because in diabetes the major reason for the death is multiple
Shrija, ma'am,
infarction.
really sorry to disturb you again, but your voice again, like it's normal and then it just gets muffled and then comes back. It's happening again. I'm really sorry to disturb
Okay,
you.
okay, okay. Wait. Thank you for telling me this. Just a moment. Because of the weather, my internet connection is not stable today. Okay, now.
Yeah, it's better, but I'll know more once you speak more. I'll let
Okay.
you know if this happens again.
Okay. So now we were talking about small vessel disease, and now what if there is large vessel disease? So mostly it is affecting cardio. So if they have given you the case of, for example, some cardio related problems, or maybe they would have given some cerebrovascular diseases, or maybe some large vessels things, for example, peripheral diseases are there. So if this is happening, they will ask what is happening in the large vessels. So when we talk about the large vessels, again, there is atherosclerosis. Why atherosclerosis here? Anyone? What is atherosclerosis and why it's happening in the large vessels?
Atherosclerosis happens due to endothelial dysfunction, which causes accumulation of you have these macrophages that proliferate, and you have oh my God, I know it in my head, but it's like you have that fatty streak development and accumulation of fats and macrophages
Right.
and smooth muscles that proliferate and cause that. But primary, it's due to endothelial dysfunction.
Yes, and there mostly the point is that diabetes mellitus is metabolic disorder. Okay, so it comes with so many problems. So hyperlipidemia is one of the reason, and that leads to more fat deposition, and it makes the vessels more stiff. So these are the reasons for atherosclerosis. So you should be clear that if this is happening in cardio, it means that you, you need to treat not only diabetes mellitus but also hyperlipidemia. So that's why I was asking. Okay, next, these are some points that they can ask you, and you should also know about some glucose tests. For example, HbA1c. You know that it should be over 6.5. So you can check that. Okay, if it is more than this, it means that patient is has diabetes mellitus, and they will give you osmolarity. So whenever they are giving you osmolarity, the question is related to diabetes mellitus or maybe diabetes insipidus. So we will talk more about it. So is insulin clear, everyone? Now you know how to solve the question for insulin, diabetes mellitus mainly. Okay. So next very important topic was with Cushing syndrome, and they will give you a very easy question from here. Because they will give you a classic case from here. So now let's talk about Cushing syndrome. So what is pathophysiology of Cushing syndrome? Anyone? Okay, so the pathophysiology is increased cortisol, and there could be many factors for this. Maybe someone is taking some drugs, glucocorticoids, or maybe there is some adrenal cancer, or maybe there is some pituitary adenomas that can lead to excess of cortisol. So these can be the reasons. But let's see. This the first factor is increase in cortisol. But they won't ask you this. They will give you the findings. What are the findings? What are the clinical symptoms? How will you detect that this is Cushing syndrome?